Good evening. So I'm Dr. Darron Halliday. I'm a gynecologic oncologist. I did most of my training at the University of the West Indies for both undergraduate and postgraduate. Then I went off to Canada to the University of Calgary to study gynecologic oncology. The role of a gynecologic oncologist is one who would treat and coordinate the care for cancers of the female reproductive system. So we say prevention is better than cure, or we could say checkup is better than a patch up or fix up. For the sake of completion, look at cervical cancer prevention and diagnosis and treatment. So as we are aware that cervical cancer is not a new problem, it always presents late, meaning in the advanced stage. And this is the case in the majority of the world where they don't have good screening programs. Global statistics note over 600,000 cases annually, with a majority in the developing world. It is the fourth most common cancer globally. However, in countries with good screening programs, cervical cancer is the number 3 gynecological cancer. And we see high incidence in the developing country according to GlobalCan data. Majority of the countries are under-screened, and is well established that the more your screening coverage increases, the incidence of cervical cancer decreases. Now, we know that cervical cancer is caused by the human papilloma virus, and this work was elegantly done by Harold Zura Hansen, for which he won the Nobel Prize. We know that HPV is sexually transmitted, and there is some transmission to the fetus if there is active lesions at the time of delivery. So we want to prevent all of this because it is costly to treat, both in the US and in the Caribbean, and it's a significant cause of loss of life. Now, we mentioned HPV as the most common risk factors for cervical cancer, but other risk factors would include smoking, multiple sexual partners, somebody who is immunocompromised due to organ transplant or any form of immunosuppression, HIV, other sexually transmitted. All of these things would put persons at risk for cervical cancer. The incidence of cervical cancer increases with age, and we want to emphasize that prevention is better than cure. Depending on the resources of a country, they will decide if they will screen by pap smear and HPV tests, or visual inspection with acetic acid. But because screening rates remain low, the WHO has pushed vaccination. And the good thing about the vaccine is that it's available. We would recommend 3 doses from the ages of starting at age 12 up to 26. They got secondary approval after 26 with discussion with the healthcare provider. It's approved for use in boys as well. Gardasil 9, which protect against more high-risk type, introduced in 2015. And it is now known that in young women, 2 doses, and in special circumstances, 1 dose is sufficient to get a significant reduction in incidence of cervical cancer and cervical dysplasia. It is more than 99% effective when vaccinated against the specific type of HPV. With respect to screening, we're most familiar with the pap smear, and where we would visualize the cervix and swab it with a a spatula or a cyto brush and put it on a slide or in a fixative, where we aim to remove the superficial layers and send for testing. And we would look under the microscope and based on those results, determine the need for further treatment. And even in the introduction of the Pap test in Dr. Papanicolaou's lifetime, the rate of cervical cancer decreased by 50%, and we continue to see strides. Now, in areas where Pap testing is not available, the human papilloma virus has been advocated, but also we know that even before there is gross disease in terms of cervical cancer, if we stain with Luger's iodine or we stain with acetic acid, we can apply it to the cervix and we would see that the abnormal areas would stain white. This would guide us as to the area we need to treat or biopsy. Even though we know the HPV test and Pap test get the best results, visual inspection and VLI have been shown to be effective in reducing the incidence of cervical cancer. The American College of Obstetricians and Gynecologists, the American Cancer Society, and the American Society of Colposcopists and Cervical Pathologists, they recommend that no screening should be done before the age of 21. And most of these women would be protected by vaccination. In women 21 to 29 years, we recommend cytology. So that is a Pap test every 3 years. From the age of 30 to 65, we can do a primary cytology, or we can do the HPV test by itself. The healthcare provider can do it, but recently there's been approval of the self HPV test, which is available in the US, not yet available in the Bahamas, and co-testing, which is where we do the cytology and the HPV test. If you haven't had an abnormal pap smear and you require a hysterectomy, then we would recommend that you don't need any further cancer screening. And the reason is why the incidence of cancer of the vagina and the vulva is much lower compared to cancer of the cervix. The WHO guidelines, they tend to reflect the need for most cost-effective approach that could be applied globally. In general, if there's an abnormal result, we want to look under the microscope, apply the dyes, look for abnormal vessels and irregular areas, and then we would go on to do a biopsy and do the necessary treatment, which is to freeze it, burn it, laser it, or cut out the abnormal cells. So after there is healing of the cervix, everything would turn back to normal. And then we will decide how to follow you up with a Pap test or an HPV test. Okay, so let's get into the management of cervical cancer. Now, when we look under the microscope, we see that the cells could be either flat like the skin, we call those squamous cells, or they could be glandular, meaning they produce slime and mucus. And it could be mixed. It could be a combination of both. Now, if we were to guess, in terms of the symptoms, and the symptoms of advanced cancer, we have would it be pain in the legs and swelling in the legs, bleeding from the rectum, or difficulty or straining when you pass your stool, or blood in the urine, or persistent hemorrhage and uremia, which is like kidney failure and the poisons building up in the body. Yeah, so it will be all of the above, depending on the stage. Often there are no symptoms at all, and we pick it up with an abnormal pap smear. Sometimes there is bleeding or bleeding after sex. Sometimes there is a discharge from the vagina and it smells bad all the time. Those of us who are in the field, sometimes we could walk past a patient and they have that smell of necrosis. the patient literally smells like rotten meat. And that's not a good thing at all. And sometimes there's discomfort when they pass the urine. There's the bleeding could be so severe that people would black out and come into hospital and require transfusions. And as the cancer grows, it can grow into the bowel. So poop comes through the vagina. It can grow into the bladder. So pee comes to the vagina. Then you could get blockage of the tube that connects the kidney to the bladder. That's the ureter. That will cause renal impairment. And as the glands get blocked and the fluid from the legs can't drain, we would say that the patient has lymphedema. And of course, as the cancer spreads to the bone pain can be excruciating. It can spread to the liver. I've seen cervix cancer spread to the heart, can spread to the lungs and cause shortness of breath and fluid around the lungs, and it can spread to the upper belly and cause fluid in the belly, and we can elicit these findings on examination. So in the workup of patients, we often follow the International Federations for Obstetricians and Gynecologists guidelines, and these are mirrored by all the international organizations as to how we should evaluate patients with cervical cancer. So firstly, we examine them. We would do a biopsy. We would do x-rays. We would do CT scans. We would do blood tests. We would look in the bladder and the rectum with the various cameras. We'll do CT scan and MRI to see the masses on the cervix and see the various areas that it spread to. And we may even do a PET scan to figure out where it is spread to. Now, all of this is important because the survival depends on the stage. If we catch it early, we'll be able to treat it with great success, and the majority of people would survive. Not to be too technical, stage 1 disease is disease that we can't see with our eyes, stage 1A. Stage 1B is disease that we could see with our eyes, but still confined to the cervix. Stage 2 disease spread to the vagina and the tissue next to the vagina. And stage 3 disease spreads to the lower vagina or the side wall. And if we check, the side wall means it press against the blood vessel, it blocks off the tubes that connect the kidney to the bladder. And if we look on imaging, or if we determine after surgery, it spread to the glands in the pelvis or the glands in the upper belly over the big vessels called the parotid glands. And stage 4 disease is if it erodes into the bladder and the bowel, as we discussed, and distant mets, meaning it spreads to the upper belly, the bone, the liver, and the other organs. How we treat would depend on the stage. And remember that much of our treatment is to correct a lot of the complications associated with the growth of the cancer. So thankfully, for early stage disease, which is microscopic, if we cut it out with what we call a cone biopsy, or we remove the womb, then the chance of a cure, as we said, is over 90%. And with each stage, as you noted, the survival is less. But every time we have to do something more aggressive, we see that the complications increase. I would rather spend my days doing pap smears because I know I could prevent a lot of suffering because of the symptoms of the cancer, even though in modern science, our complication rates are around 5 to 6%, and depending on the procedure, up to 10% complication rate. A pap smear and the treatment of the pre-invasive disease carries relatively no complications compared to these more invasive procedures. So for a hysterectomy, we have bleeding, blood transfusion. Complications of blood transfusion is could be incompatible. You could have allergic reaction. The blood transfusion can cause your lungs to react and collect fluid. If you are anemic from and bleeding heavily from the cervical cancer, you would also need blood transfusion. And of course, we know, as I'll mention later, there's a risk of bloodborne illnesses like HIV and other things with blood transfusion. Then we have clots in the legs. If clots from the legs go to the chest, you could die from that. There's infection post-op. Even though we give antibiotics at the time of surgery, there are so many factors that influence whether or not people get infection from whether or not they're immunocompromised. Nutrition is one factor, so it's sometimes difficult to predict, even though we use sterile equipment and use strict aseptic methods and sterile gloves and all of those sorts of things. Then there's injury to the surrounding structures, and there are complications related to anesthesia, allergic reactions to all the medications. So we could injure the bladder, we could injure the bowel, and if we injure the bowel, then you could get a severe infection. And then if we have to do something called a radical hysterectomy, the blood loss is double compared to a simple hysterectomy. And sometimes after the radical hysterectomy, the main difference being with a simple hysterectomy, we take the womb and the cervix. For a radical hysterectomy, we have to take the tissue next to the womb, called the parametria, because the cancer spread there. We have to take the upper vagina, and we have to sample the lymph nodes. And the complications of what we call pelvic and parotid lymph node dissection is lymphedema, meaning we sample the glands so the fluid can drain from the legs properly, so the legs not pretty anymore, they swell up. Fortunately, we don't see that too often, but it could be quite debilitating. We see it a lot more in breast cancer. I don't know if you notice some women wear the sleeve on one arm after they have the glands removed from the arm. And the same thing can happen in the legs. Patient with risk factors for the cancer coming back after surgery. This has been studied by Stellis and people like that, Delgado and groups like the Gynae Oncology Group in the US. All of these risk factors, the histological type, the size of the tumor, how deep it invades into the substance of the cervix, and the pattern of invasion, whether the nodes are positive, all of these things would signify the need for radiotherapy. And if the cancer is more than 4 centimeters, we do not operate. We would give radiotherapy and chemotherapy. And radiotherapy is essentially high energy X-rays, or you could call it of high energy microwaves. And we would use the computer to help to guide where those rays would go. Fortunately, Bahamas has a radiation machine, and it's in the cancer center on Collins Avenue. But I want to emphasize here that even though we get good cure rates with the radiotherapy machine, also depending on the stage, one of the side effects of cancer care is what we call financial toxicity. All cancer care in the government health services must be paid for. The chemotherapy costs several $1,000s. External radiation, which is what we call teletherapy, costs around $16,000, and the internal radiation also costs $16,000. So when we have to administer and write treatments for these things, what the government does is it pays all the providers, and the patient and their family needs to come up with a payment plan to pay the government back. But because the government can only do so much, they require you to come up with a down payment, and even that's a challenge. And all of this is supposed to be covered with catastrophic care under the NHI, but that is still to come. So what is covered by NHI is that you can get your pap smear today for free, and the Cancer Society, God bless their heart, I'm so thankful for the work that they do, providing free pap smears and mammograms and all the necessary cancer screening, because prevention is better than cure. And the cost of these medications and treatments are astronomical. Chemotherapy helps radiation to work better and improves overall survival. That's been brought out by several studies. And sometimes in very advanced disease, often no matter what we do, the survival is less than 10%. The chemotherapy, as I said, we can give very high doses of chemotherapy, and we give radiation, not enough to get a cure, but just to stop the bleeding. And sometimes we have to resort to very radical surgeries for recurrent disease and for advanced disease. Chemotherapy, which is what we call platinum-based chemotherapy with all sorts of other drugs like paclitaxel and topotecan. Just remember, when we have to give high dose with curative intent, these medications, although many tolerate them well, they're not without side effects. For example, cisplatin can cause loss of hearing, kidney problems, numbness in the hands and feet, and it can cause low blood count, put you at risk for severe infection, nausea and vomiting. And the side effect is similar for what we call cytotoxic chemotherapy. The targeted chemotherapy is the bevacizumab, even though it's shown to improve survival, the cost is $10,000 per month for the treatment. And that's associated with high blood pressure, perforation of the bowel. And even though it works, and even though those complication rates are low, when we see them, they can be quite dramatic. What's new is to add immune therapy, or what we call targeted chemotherapy, based on the Keynote trial, a drug called Keytruda. And even though that helps and takes the survival from death within 4 to 6 months of diagnosis of advanced cancer to 2 years, which is bright, the cost is astronomical and is not readily available at PMH. And the side effects include a generalized inflammation of all the systemic structures, inflammation of the lungs called a pneumonitis. It can cause a nephritis, kidney problems. It can cause endocrine disruption. It can cause so many problems that I cannot emphasize enough that we should do a pap smear. The pap smear is easy, a little bit embarrassing, a little bit of discomfort, but a stitch in time save nines. And all of these remedies have been substantiated by various trials. Then I had begin mentioning the complication of blood transfusion. Now we always have a crisis of no blood in Princess Margaret Hospital. I would tell you from one of the most tragic things I've had to see. A patient came to clinic and she went to the bathroom while getting chemotherapy for her cervical cancer. She started bleeding. She continued to bleed. She passed out. We tried our best to resuscitate her. The bleeding wouldn't stop. And because she had advanced disease, if we took her to the operating room, we couldn't cut it out because Often when the cancer is so big, when we try to operate, you can't stop the bleeding in the theater. Plus, where we would need to clamp the vessels, the tumor is eroding through them. So I had to watch this young lady die before me, and there was nothing I could do. And prevention is better than cure. And when we survey people, the reasons why they don't do the pap smear is inconvenient. I have to take time off from work. I don't like the doctor. It's uncomfortable. And I have the unfortunate experience of having to watch people die before my eyes. Okay? Because we're not able to do anything. And up to 50% presents with stage 3 disease where there's renal failure and blockage of the ureters. So, to get them stable, we have to dialyze them. Dialysis is a few $1,000s per treatment. The government pays for that. Then, once they get stable, if they become stable, we have to put tubes in to relieve the blockage from the kidneys. So we put them to sleep, put a camera in the bladder. We have to get other specialists involved, like urologists, and put tubes to relieve the blockage. If that doesn't work because sometimes it's so intense, then we have to put tubes in the back and you walk around with pee coming from your back until the cancer shrinks and be able to get them inside, or sometimes for the rest of your life. So you're walking around smelling like pee because the pee is coming all the time. You know, it causes people to isolate themselves. Then there's complication from the tubes. They often get infected and have to be changed every few months. So they get infected and we have to change them. And a lot of our patients die from sepsis related to the placement of the tube, but it's a necessary thing if they're to have a chance. Then sometimes we may have to cut a piece of ball out, connect the tubes from the kidneys to that tube and bring it to the skin. That's called an EL conduit. Complicated surgery. And even after surgery, you can get electrolyte abnormalities, which can cause you to be on lifelong medications. And then there's frequent infections. Then if the stool comes to the vagina, in order to prevent you from getting urinary tract infection, we have to bring the bowel to the skin. And that's called a colostomy. So not only do you smell bad from down below, the poop is coming through to the surface of the skin. And even though people have to live like that, often this improves their quality of life and give us the opportunity to get the treatment in and very occasionally be able to reverse it. Oftentimes it's permanent, and this causes significant lifestyle change, the rupture of intimate relationships. Now sometimes we have to cut out the bladder, the vagina, the rectum, either for recurrent disease, and in some places in Europe they will do it for primary disease. We tend to reserve it for candidates who we think would survive and have a good quality of life afterwards. But you end up with a bag for pee and a bag for poop for something that could have been prevented with vaccination and a pap smear. It's concerning that many women will still fail to get a pap smear, and I think it's due to not a full understanding of some of the struggles we have to deal with. Now, this procedure called pelvic exenterate is a big procedure. You need lots of blood. You would have to stay in ICU. You tend to stay in hospital for 4 to 6 weeks after. The mortality when the was first introduced was very high. It's significantly down these days, but it's still significant due to infection and leakage of the anastomosis and that sort of thing. So these are things not to be taken lightly, and it can be prevented with a pap smear. So that's something very concerning. Now, nowadays they're doing a lot of work on the quality of sexual function. The surgery by itself would cause loss of desire, decreased excitement. We might have to take the ovaries out, so you get premature menopause, you get pain. There's a lot of emotional problems. You can't get together with your husband. You smell bad. There's stool coming from the vagina. Even if we're able to cure you, there's vaginal dryness, narrowing of vagina. You have to use dilators for life. It is not something pleasant. So I advise everybody to get the pap smear, get the vaccine. Prevention is better than cure. Stitching time save nine. Early stage disease, the survival is over 90%, but less than 10% for stage 4 disease. And that's when we throw the book at you. And even though there is hope with targeted therapy and individualized medicine, these are expensive and often beyond the reach of many of our patients. And the pap smear is within reach. It's something everybody has access to because NHI and the efforts of the Cancer Society. So once again, I implore everybody to get a pap smear. And then even after treatments, we have to follow you because after all of that treatment, the cancer is at risk for coming back, and you have to see the doctor several times each year. Cervical cancer is a problem. Advanced diseases difficult to treat. Screening prevents death, morbidity. It has a significant financial impact. And we haven't even discussed the social impact where mothers die and leave their children behind. The youngest patient with cervical cancer I've seen in the Bahamas is 22 years. And this is preventable. If we catch it early, then we can help you a great deal and even maybe achieve a cure. And if you get vaccinated, you may even, because the vaccines are so effective, you may not even have to have all those procedures to treat pre-invasive disease. The vaccines are not 100%, so you still need to get your pap smears, but the risk of cervical cancer is greatly reduced. So I'll end with this. The WHO vision towards the elimination of cervical cancer is that they want to have by 2030 90% of girls fully vaccinated by age 15. They want to have 70% of women screened, and they're moving to primary HPV testing, and they hope that they will get an overall 30% reduction in global mortality. Thank you for the opportunity to share. And indeed, from reviewing this material, we see that a stitching time can save nine and prevent a lot of heartache and sorrow in the long run. So thank you very much.
Well, thank you, Dr. Halliday. That was very, very informative and like a punch in the gut reality on why women should be screened for their regular pap smear.